From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
Hello to our listeners from around the world. You're listening to JAMA Neurology Author Interviews. Thanks for joining us. My name is Dr. Cynthia Armand, Associate Professor of Neurology at the Albert Einstein College of Medicine, Montefiore Medical Center, and JAMA Neurology web editor. Brain arteriovenous malformations, also known as AVMs, are high-flow cerebrovascular lesions with great potential to cause intracranial hemorrhage and epilepsy. What is the rate and risk factors of future hemorrhage from unruptured brain arteriovenous malformations? Dr. Helen Kim is here to discuss work of her and her colleagues and answer that very question. Dr. Kim is a professor of anesthesia and epidemiology and biostatistics at the University of California, San Francisco, where she's the director for the Center of Cerebrovascular Research. Her research interest is focusing on identification of stroke and cardiovascular risk factors in young individuals. Dr. Kim, welcome to the podcast.
Thank you so much for having me.
Now, arteriovenous malformations, very scary to our patients when we identify them. What do we know currently about managing them? And how did you develop this research question for this study?
Yes, so thank you for the question. So management of patients with brain arteriovenous malformations can be quite challenging because the difficulty in weighing the risk benefits of interventional treatments, either used alone or in combination with microsurgical resection, endovascular embolization, or stereotactic radiosurgery versus conservative management of medical symptoms. So if patients present ruptured, it's very clear that they need emergent surgery, hematoma evacuation, etc.
Right.
But if patients present unruptured, I think there's a lot more uncertainty in how best to manage those patients, especially given the trial results that were published in 2014 that demonstrated that patients that were randomized to medical management were at significantly lower risk of hemorrhage compared to those randomized to any interventional therapy.
So it's very clear with ruptured arteriovenous malformations. What do we know about the standard of care for the unruptured AVMs? What kind of discussions are had with patients, and what factors do we take into account in terms of surveillance and when to move in on it?
Yeah, so when clinicians discuss treatment options with patients, they typically will present what those risks are in the treated course, as well as what the risk of hemorrhage is if left untreated. And that's typically cited as 2 to 4% per year is the risk of rupture in unruptured brain AVM patients. And so treatment decisions are based not only on recommendations by clinicians, but also patient preference. So these risk estimates become really important in trying to weigh the risk benefits of whether or not to treat an unruptured brain AVM.
Were there any precursor studies that were done to your current study in order to figure out, in a more streamlined way, how the rate and risk factors for future hemorrhage can be incorporated in these discussions with clinicians and patients?
Yes, there's been a lot of studies published, but primarily these studies have been single-center studies from referral-based cohorts with just a couple of hundred patients at most. In general, brain AVMs are a relatively rare disease.
Right.
And so it's very difficult to conduct large-scale studies. And so the risk of hemorrhage rates and then risk factors that stratify this risk have really been based on these older, smaller single-center studies or aggregate meta-analyses of these previously published studies. So we wanted to improve upon that in the current study by conducting a very large multicenter international study of patients with unruptured brain AVMs.
So tell us about your study currently, the setup and methods.
In the current study, it's called Multicenter Arteriovenous Malformation Research Consortium, or MARS for short. And this was a multicenter international study that included initially 12 cohorts, and then in the actual analysis, data from 9 of these cohorts. And so we really wanted to focus on a representative population of unruptured brain AVMs. So included cohorts that were both from high volume referral centers as well as defined population-based studies, both from the US as well as abroad. And we performed a prospective follow-up study to try and identify risk of hemorrhage in the unruptured or natural history course of unruptured brain AVMs.
I see. And what were the demographics like? And were there anything about these unruptured AVMs that were followed in terms of like their characteristics?
Yeah, so the overall characteristics of our cohort were representative of the geographic distribution of the catchment areas that these cases are seen at.
Hmm.
But overall, the median age at diagnosis was in the mid 30s, 38 years. Half were female, and about 77% or a quarter were non Hispanic white race ethnicity.
Within the demographics of the patients, and specifically in the AVM characteristics, was it taken into account whether or not these AVMs were sporadic or genetic? Did we know about familial AVM in terms of that information for the patients in the cohort?
Yes, that was actually one of the exclusion criteria for the study. We wanted to make it as similar as possible to the Aruba trial results.
Okay.
So the vast majority of patients are sporadic AVMs. So if they had multiple brain AVMs or a known familial or genetic syndrome in which brain AVMs are present, we excluded those cases from this analysis.
Hmm. Okay, that's great. And the other characteristic, as we all know, AVMs can be associated with aneurysms via afferent or efferent connections. And that can lead to increased risk for rupture. Was that taken into account in terms of the makeup of the AVMs in this cohort?
Yeah, so we did collect whether or not there were flow related associated aneurysms with these AVMs. So we considered those that were in afferent vessels as well as intranidal aneurysms.
So, how many people in this cohort? What was your final number with patients who were excluded, right? The final number. And tell me about the primary outcome that you were looking for and your secondary outcomes.
Yeah, so we ended up including just over 3,000 individuals, so 3,030 patients with unruptured brain AVMs from 9 MARS sites in the study.
Can you talk to us about the primary outcome, which I would think is time to the first intracranial hemorrhage?
That's correct.
And then any secondary outcomes that you're looking into?
Our primary outcome was time to first hemorrhage or ICH in the untreated course. So patients were censored at date of first treatment, death, or last follow-up. And the follow-up time started after diagnosis.
Hmm. Hmm.
That was our primary outcome. We did look at stroke and death,
Okay.
but we felt that it was really important to just focus on what is the risk of hemorrhage as our primary outcome.
Hmm. Now, in terms of the risk factors, did you have a list of particular risk factors that you were following, and what were they?
Yeah, so we took a pragmatic approach. So this was an international study, multi-center. So we focused on risk factors that we thought were readily available from medical records as well as across the cohorts. When we started the study, we agreed upon a standard clinical protocol and defined these key variables for data collection.
Hmm.
And so many of these ended up being ones that have been previously investigated in prior studies, but have not necessarily been consistently associated with risk of hemorrhage.
Hmm.
So in our table, we actually list all of the risk factors that we collected and had initially looked at.
Hmm.
So we looked at demographic characteristics, we looked at clinical characteristics such as symptoms at presentation, the history of hypertension, lipidemia, diabetes, history of alcohol use, history of smoking, these modifiable risk factors that have been associated with, for example, aneurysmal rupture.
Right.
And then we also looked at angiographic characteristics, such as location of the AVM, it's an eloquent location. These are all important risk factors that have been looked at before.
I see. Without further ado, tell us about the results.
Yeah, the main finding of our study was that we found that the rate of hemorrhage in the natural history course of patients with unruptured brain AVMs was about half of what had been previously reported. So we found that the rate was 1.4 per 100 person years, or stated another way, about 1.4% per year was the annual risk, whereas before, prior studies have estimated that to be about 2 to 4% per year.
Wow.
Because we had such a large sample size, we were able to narrow the confidence interval of this estimate so that the true population rate of hemorrhage would range between 1.2 and 1.64, given our 95% confidence interval estimate.
Well, when I think about this and the size of the cohort as compared to the other previous studies, I would expect the generalizability of a study like this to be much better. For this rate that's lower, makes me feel a lot better about it in terms of me discussing this with patients.
Yeah, that was one of the reasons why we conducted this study, because previous studies have been done mostly in smaller sample sizes because of the rarity of the disease. And so by performing an individual patient data meta-analysis of this very large cohort of over 3,000 individuals with follow-up time, we were able to really hone in on a more precise estimate of hemorrhage.
Yeah, no, that's fantastic. Now, tell us about the risk factors, because
Yep.
naturally I want to know, who am I following very closely? Obviously, all of these patients are followed closely, but who am I paying attention to? What kind of conversations I'm having with risk factor modification in terms of rupture?
So we found that increasing age at diagnosis, so the oldest age group, so those over 60 years of age compared to the youngest, are at highest risk, about twofold increased risk. We also found that the presence of associated aneurysms or an AVM in a cerebellar or supratentorial deep location were also at about a 1.6 to 1.9 fold increased risk.
Got it. Okay. So those are the characteristics that we need to pay attention to and to make sure that, okay, if it's in this location or this demographic.
Yeah, so these were the risk factors that remained significant after adjustment for multiple significant independent risk factors. So the
Mhm.
way that we did the analysis is we looked at each individual risk factor and we included them in a multivariable model if they were significant at the univariate level.
Got it. What do you take away from these results? Because I think what a lot of our listeners want to know is, all right, this is an awesome study. We have a large cohort, we've got good generalizability, and we have more information. What do I tell my patients?
We hope that the results will be incorporated into clinical practice. I think it's really important to understand what the rate is in the natural history course. And so the fact that we found that the rate was about 50% lower than what was previously reported, I think is important, not only for the clinicians, but the patients to make informed decisions about their treatment options. For example, a risk-averse patient may be less inclined, if they don't have any risk factors, to have their brain AVM treated, because unruptured brain AVM treatment is considered elective surgery
Right.
or an elective procedure.
Right. Dr. Kim, thank you so much for this work of you and your colleagues. Any closing thoughts from you?
I just want to thank all of my collaborators. I think team science is so important, and it's the only way to answer some of these lingering clinical questions, because randomized clinical trials are not always going to be feasible. And so it takes a tremendous amount of energy and effort to bring together these fantastic teams to work together to answer clinical questions. So this has been truly an amazing experience, and hopefully will make some very important contributions to the field.
What's next in your research endeavors?
Yeah, so I think we still have a lot of work to do. We hope that these results will still need to be validated in external populations. We hope that we can identify additional or novel risk factors that further stratify risk. And if these results are validated, then we can start building risk prediction models. And these tools can be used bedside that can calculate individual risks for patients for their specific risk profiles. And so I think that will be an important contribution. We're not quite there yet, but we're getting closer.
We're getting very close, and I look forward to more on this topic and to better inform us as practitioners and our patients as well.
And can I just put a plug in that this is just the first of many studies that will be forthcoming from the Mars Consortium. So stay tuned. We're very excited.
Okay, you heard that here. Look out for the Mars Consortium information, and I will be waiting eagerly. Thank you so much, Dr. Kim. I'm Dr. Cynthia Armand, and I've been speaking with Dr. Helen Kim about the rate and risk of future brain arteriovenous malformations. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for the JAMA Network wherever you get your podcasts. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.